All right, welcome to another episode of ICU Doc Talk. I'm the ICU doctor from TikTok, and today I am talking about the importance of doing a physical exam. I know that does not sound very exciting, and it's usually not very exciting. The reason I want to talk about this today, for those that are not aware, a physical exam, in medicine is actually putting your hands on a patient's body and examining them. Okay, it's not a novel idea, right? Of course. It's becoming a little bit of a lost art, and that's even a little bit of an understatement, I should say, because sometimes people just don't even do physical exams, right? Physicians, clinicians, whoever, won't even put their hands on a patient's body as a way of figuring out what's going on, and that is a big problem. Medicine is becoming like all kind of fractured in terms of all of our diagnostic tools that we have, which are very good, right? We have amazing technological advancements to have all these to diagnose patients, right? From imaging, from all these different things that we can do. And what I'm stressing today is that actually, when a patient is really going downhill, right? You're in a patient's room and they're going downhill and something is wrong. You need to do a physical exam. It is a key component of figuring out what is going on with that patient, and it will guide you. Now, I'm going to include this today, so not just a physical exam, but I'm going to talk about point-of-care ultrasound. Taking an ultrasound during these times of the patient is crashing, putting an ultrasound on them, and how incredibly useful that can be, because that is an extension of your physical exam. I just consider it part of the physical exam, doing an ultrasound. I'm going to go through ultrasound, what it is, when we use it. So here we go. All right, let me start this off with two stories. So I go to a lot of code blues, right? That's what we call in America for cardiac or respiratory arrest. Someone is pulseless often. Doesn't mean their heart is stopped, but that's usually what we associate with a code blue. So I go to many code blues, and I run code blues and with a team. And I've talked about that in other podcasts. So here's a story. Oh, so no, let me back it up. So there's code blues, and then in the United States, we also have rapid responses, which is like, it's not a code blue, but it's like a rapid team that comes to a patient's room to assess them, to see if there's anything we can do. It's usually to prevent someone from going into cardiac arrest. So I went to there was a rapid response, maybe it was called the code blue as well, but I went to a patient's room, not in the ICU, in the general wards. So I go to the patient's room, and there's just a lot of people in the room already. And I've mentioned on a previous podcast that my approach to a room like that is there's a lot of noise pollution already. I walk into the room, and I usually don't say anything right away. I just look at what's going on with the patient. I look at what people are doing to the patient. I look to see if there are vitals, and what are those vitals, and then I perform a physical exam. That is the step. Those are the steps I take. Typically, sometimes when more action needs to happen right away, I'll speak and be like, we need to do this right now. Obviously, I'll speak up if I feel like I'm needed to speak up in that moment. Anyway, so I go into this patient's room. And I come in, and I don't know anything about these patients, right? When I'm called to these, I don't know these patients. They're just random patients in the hospital that whose care I have not been involved with. That's part of my job as a critical care doctor, that I show up during times, these events that are happening in the hospital. So I show up in the patient's room, and I immediately see the patient has a tracheostomy. That's a breathing tube that's been surgically placed on the neck. And there's like 3 people or 4 people around the bed, and they're really focused on the tracheostomy, which I understand. So I'm like, okay, this patient's probably in respiratory arrest of some sort. They're in respiratory failure, something's happening. And everybody's focused on that trach, which I get that. And I look at the trach, and the trach looks fine. And what I say about looks fine, it looks like it's in the right place, and there's not blood coming out of it. And there's a bag on there. It looks like the patient's kind of breathing through it. And I'm like, these people are assessing the trach, so they will assess it, and I will hear what they're talking about. I don't need to get in there and dig around that trach. Not dig around, but you know what I mean. And then I go and listen to the patient's lungs while, this is happening. The patient is clearly struggling to breathe. I listen to the patient's lungs, and there's just wheeziness all over. There's just so much wheeziness going on in these lungs. Like, it's crazy how much wheezing is going on. When someone has wheezing lungs, it usually means their conducting airways of their lungs are all constricted down. They have asthma or COPD. or they're called what we call bronchospastic. Their bronchi are spasming. The wheezing was so profound, I knew I was the first person to listen to that patient's lungs because if anybody else had listened to those patient's lungs, they would not have been focusing on the tracheostomy. Now, I don't say this to be critical of the management of anybody else in that room, but the reason I'm saying this is, what is this episode about? It's about focusing on the physical exam first. And now everybody else was doing a physical exam of the tracheostomy, right? They were inspecting the tracheostomy, which is definitely part of a management of people with a trach. But I would argue listening to a patient's lung is a very simple step to take in patient care before moving on to like the tracheostomy. Now, obviously, if you walk into the room and there's blood coming out of the tracheostomy, that's probably your problem, like a lot of blood. And you're going to want to get a fiber optic camera and all that and do a physical exam with a fiber optic array. Anyway, so there's wheeziness in the patient's lungs. So, and I'm like, this patient is bronchospastic. This is what is going on. They cannot breathe. They're having a COPD exacerbation. So I called for epinephrine, and I diluted that to 10 mics per cc, and I gave that IV, and it immediately resolved the patient's problems, and the patient was fine. And it was because of doing a physical exam that I was able to quickly come to that conclusion, and it quickly led to a treatment and quickly led to resolution of the patient's issues. With listening to a patient's lungs, it is not rocket science, right? It's not hard. Another story when I was in the OR doing anesthesia, right? I do both. I do critical care and I do anesthesia. So I was on an OR week. I walk in, I get an alarm in one of my patient's rooms where, I have nurse anesthetists or residents that are covering patients' rooms. That this patient their pulse ox is very, very low. So I run into the patient's room and their pulse ox is like 40. It's like 40%, right? Which is ridiculous. The surgery is still happening. There's just, and I can tell there's panic in the room. And then I can also tell that the drapes, so the patient's getting surgery and the surgeons are still working. The drapes are still up to the patient's neck. And I know nobody has listened to the patient's lungs because you have to, in this case, I could tell you to even listen to the patient's lungs, you probably have to bring down the drapes. You don't always have to do that, but I could tell how it was arranged in the room. So I ripped down the patient's drapes. I tell the surgeons to stop what they're doing. And what they were doing, it was safe for them to stop for the particular operation. And then I listened to the patient's lungs. What do I hear? Oh, crazy, crazy wheezing again, like barely wheezing at all. Again, this patient was bronchospastic. So I immediately came to that conclusion, gave IV epinephrine, gave some albuterol, resolved the patient. Patient came out of it. But that patient was close to coding. Again, physical exam, focusing on that first. When you're like panicked, you're like, oh, what do I do? Listen to the patient's lungs. And what are you listening for? It's so straightforward. You're listening for bilateral clear breath sounds on both sides. If you hear bilateral clear breath sounds, you move on. It takes 2 seconds to listen to breath sounds. Number one, they're not apneic, right? So maybe they're not like overdose on opiates if they don't have a breathing tube on the floor and they're moving air. If you don't hear wheeziness, you're like, okay, they're not bronchospastic, they don't have COPD, they're not having an asthma exacerbation or anything like that. And then bilateral rather than unilateral. They have breath sounds on both sides. If you only hear breath sounds on one side, you can be like, that could be like a pneumothorax. So if you hear bilateral clear breath sounds immediately, which takes 2 seconds, you are ruling out COPD exacerbation or bronchospasm. You're ruling out a pneumothorax, which is a collapsed lung. And you potentially are also ruling out a tension pneumothorax. And you're confirming that the patient is still breathing on the room. That's it. And then you move on. You move on from there. And then I listen to the patient's heart. Sometimes you can't hear the heart that well. If there's a lot of confusion, a lot of in the room is a lot of noise, sometimes you can't hear the heart that well. And I would say when a patient's heart, in these, keep in mind, I'm a critical care doctor and anesthesiologist. I'm not like a primary care doctor. So I'm listening for like big things, for like big problems, right? So if there's like a small murmur that someone's had for years and years, I'm not looking for something like that. I'm looking for like harsh, hollow systolic murmur that is consistent, like that. Oh, something is wrong. Like a valve, like, wow, the mitral valve is rip roaring wide open, right? There's some sort of acute valvular problem that's going on here. You can listen for a friction rub, which is a sign of pericarditis. But a basic cardiac auscultation means to listen, is in an acute setting, usually is not that revelatory. So I don't like spend a whole lot of time listening to the patient's lung, the patient's heart. And then if the patient's awake, right? Depending on the situation. And if it calls for it, doing a neurological exam. Okay, talk to them. How are you doing? Okay, they're saying hello. Great, they're alert. Doing a quick, cranial nerve exam. Doing a quick upper extremity, lower extremity. See what their strength is. And it doesn't need. I'm not a neurologist. I'm not like pulling out my reflex hammer and doing like a very detailed neurological exam. If they're in extremis, and this is an acute setting, just a quick neurological exam. And to see, make sure they don't have any focal deficits that could be indicative of they're having a stroke. Because these are, again, you got to intervene on things that are happening quickly. So if they're having a stroke, you got to intervene on that. Like they got to get head CT, maybe they need lytics to break up blood clots, right? These are actionable things that need to happen right away. Another part of just a quick and dirty physical exam is just feeling the stomach, the belly, the abdomen. Just feel it with your hands. Just put it on there. Is it tense? Is it tight? Is it tympanic? Meaning, does it sound like a drum? Like, is it full of air? Is there a fluid wave? So I take both my hands, I put them on either side of the belly, and I tap on one hand, and I feel with the other to feel if there's like a fluid wave. Do they have a bunch of fluid in their belly? Do they have ascites? Do they have, from liver disease? Do they have blood in there? Are they bleeding in their belly? Is it super taut? Why is their belly filling up? Does it hurt them when I tap their belly? Maybe that's a sign they have infection or something that we call peritonitis. Again, these are really simple things, right? The extremely simple physical exam. What I'm explaining, I could do all these things in 30 seconds. And if all of these things are normal, just think about all of the things I just ruled out in 30 seconds that are going on with this patient. A lot, right? A lot. And this is one of the reasons I always keep a stethoscope around my neck. It's not just for the aesthetic, right? I'm using it. And when you need a stethoscope, with what I do, anesthesia and critical care, when you need a stethoscope, you need it right now. So I always carry a stethoscope on my person. Rather than being like, oh, can I borrow some? Not every doctor needs to carry a stethoscope around their neck, depending on what they're doing or what their specialty is, right? But for a critical care anesthesiologist, I always have one on my person. That's the only tool, medical diagnostic tool that I actually keep on my person at all times when I'm in the hospital. Very important. Okay, and then another just quick part about physical exam is just looking at their body, meaning, what does their skin look like? Do they have what's their IV access look like? Are they bleeding from anywhere? Do they have an AV fistula that was created? That's a sign that they're on dialysis. Do they have a port that's been placed? That's a sign maybe they have cancer, or they're getting some sort of chronic IV medication and infusion. And then if they're still alert and awake, I look in their mouth. Do they have dentures? What kind of airway do they have? Am I going to have to put in a breathing tube in there? How much trouble am I going to have putting a breathing tube in there? Just anything, patients are dripping with information just by looking at them and by examining them and just seeing if there's anything special or new that gives you clues about their what other medical conditions that they have. Again, can do all these things very quickly, in a minute or two, without saying a word. And then as people talk about what's going on with the patient, other information percolates to me. And I've now gathered a lot of information about what's going on with the patient without clouding the room with a bunch of noise pollution. And then obviously I can't know everything about the patient from that. And then I can start asking questions later if there's other pertinent information that I need. But what I have found is to resuscitate a patient who's going downhill, you don't need a tremendous amount of information about that patient in that moment to bring them back. What you need is the information that's sitting in front of you at that moment, and you work with that information to bring the patient back. I know it's hard when you're new in medicine, or if you're a resident med student or a fellow or whatever, the tendency is to, you want to come in when you're a patient, when this is happening, and you want as much information as possible. And that's why you talk, that's why you ask questions, because having that information, you feel more grounded, and it orients you more to the patient. Honestly, the orientation that you need to do something and act for that patient right at that moment, it's sitting right in front of you. It's the patient, and it's doing a physical exam, and just look at what's going on with the patient. Okay, so now all this brings me to point of care ultrasound as an extension of your physical exam and initial assessment of a patient that's unstable. So for those of you that aren't familiar, ultrasound, is a machine that uses ultrasound waves to then visualize them on a screen so that you can look into a patient's body. It's not radiation; it uses sound waves. It's not harmful to a patient at all. So if you think of an echocardiography, someone puts a probe on your heart to look at your heart, that's ultrasound. Ultrasound of a baby or a fetus. within the womb. That's ultrasound as well. So there's lots of different applications of ultrasound. And what does point of care ultrasound mean? Well, it means someone like me using ultrasound in the moment, not in an informal way. Meaning it's not going to be like read by a radiologist, because usually radiologists will read ultrasounds, or a cardiologist will read an echocardiography. It's just something that can be brought in the moment. That's kind of what point of care means. And then I use what I'm looking at to make my own decisions about the patient. It's not imaging for someone else. It's me. It's me using an ultrasound machine and looking at a patient's heart, lungs, and their belly to make decisions about what's going on. And that's the meat of what I want to talk about right now. So here's how I perform everybody has a way of doing point of care ultrasound. But it is a crucial part of critical care practice. Here is how I usually go about things. Depending on what's going on, right? It doesn't matter which organ system you necessarily start with. Sometimes you would want to start looking with the heart if you suspect something there, or you want to start looking at the lungs if you suspect like a pneumothorax, like a collapsed lung. So whatever. But I'm just going to say I'm going to start with I have a patient here. I have time. They're not like totally crashing. We're not doing chest compressions. I'm going to look at this patient's heart. I'm going to look at their lungs, and I'm going to look at their abdomen. So let's walk through that. So there are 4 spots to look at with a patient's heart in point of care ultrasound. And I won't go into too much detail, but I usually I start with the peristernal long axis, and then I go to the short axis, and then I go to an apical forechamber, and then I go to the subxiphoid or the substernal. If you're non-medical, just throw out these terms. It's okay. You don't need to remember this stuff. I'm just going to tell you what I look for in each of these views. And you need to do all 4 of these views to get a full global picture of what's going on in the heart and to rule everything out. And again, why am I doing this? Because I'm ruling out a ton of issues that might be going on with this patient. So when I do a peristernal long view and I look at the patient's heart, you're getting as the view describes, a peristernal long view of the left ventricle. And you do get a little bit of the RVOT at the top of the screen, the right ventricular outflow tract. A lot of people call it the right ventricle, but it's not. You're looking at the barrel of the gun of the RVOT. Anyway, I swear I won't go into too much detail here. What I'm looking for in this view it's 4 basic things. Is the mitral valve, the anterior leaflet of the mitral valve, is it hitting the septum of the heart rigorously? Is it moving up and down, or is it just kind of barely moving? That's a surrogate for the ejection fraction. I want to make something very important. Crystal clear here. I am not a cardiologist, and I am not determining an ejection fraction. I'm not being like, oh, this ejection fraction is 65%. Oh, it's 40%. Because I'm not doing a formal echocardiogram, right? I'm doing a point of care ultrasound. I'm just getting a qualitative feel for what's going on with this patient's heart for myself and my own assessment, based on my experience looking at many, many, many hearts. So I look at that mitral valve, is it going up and down? That's number 1. I look at the mitral annulus. Again, you'll need to refer to images for this. The mitral annulus is kind of this pyramidal-shaped, it's the annulus. You're looking at a cross-section of the mitral annulus. How rigorous is it moving? Is it really like pendulous, swinging back and forth, or is it barely moving? Again, that is a surrogate for ejection fraction, how well the heart is moving. You can even calculate something called the E-point septal separation with the mitral valve. Don't worry about that, but you can look that up if you're interested. E-point septal separation can give you a quantitative look at how well the heart is moving with the anterior mitral valve. And then the other thing I'm looking at is the myocardium thickening everywhere, not just moving, thickening. Does it get thick and thinner during diastole and systole? Because a healthy myocardium gets thick. It doesn't just move, right? You can have dead myocardium that's moving because it's just getting pulled back and forth by the other healthy myocardium around it. And then I'm looking at the left ventricular cavity. Is it actually getting smaller in systole, or is it remaining the same while the heart just kind of moves? Because again, if the cavity is actually not getting smaller, you're not having an effective blood flow through the heart. I'm looking at those things. I'm also looking at the pericardium. Do I see an effusion? Because you can see an effusion in this view. You cannot rule out tamponade in this view. That's for the apical forechamber. You cannot rule tamponade out in the peristernal long view. Anyway, and then I am taking a look at the RVOT at the top. Is it big? Is it small? But again, you got to be careful with this view. You cannot rule out that you cannot look at the RVOT and be like, oh, the RV is big, because you might be getting a foreshortened view of the RVOT, and it's giving you an exaggerated view of the right ventricle. All right, moving on, you turn it to the short axis view. Now you're looking at you're doing a cross section of the left ventricle and the right ventricle. You're just like axial cross section. So you're looking at it's a circle. You're looking at the circle of the left ventricle. What am I looking at here? Well, now I'm seeing all distributions of the coronary arteries, right? And I'm looking for dyskinesia and akinesia, right? Is it squeezing in concerted effort, or is there just kind of this jittery appearance to how it's moving? I want to make something all clear here as well. I am not a cardiologist, and I'm not saying this is a anterior septal infarct, because I don't have the trained eye to be I can tell that this coronary artery is out. But I can be this is disjointed, how this myocardium is moving. It's not smooth. Maybe there's a regional wall motion abnormality going on here, which would prompt me to then get a formal echocardiogram. I'm also looking at the papillary muscles. Are they kissing? Or is there a nice space between them during systole and diastole? If they're kissing, the patient is probably underfilled. They're low in volume, and maybe they need some blood, or they need albumin, or whatever it is. And now I'm also looking at the RV, the qualitative shape of the RV and the septum. Is it overloaded? Is it super big? Is it pushing the septum into the LV? Is it flattening with something that we call the D sign? I'm now looking. This is giving me a clue if we have RV overload. And now let's go to the apical four-chamber view. Now you're looking at all four chambers, both ventricles and both atria. Again, I'm looking at dyskinesia. I'm looking at akinesia. I'm looking at how well the valves are moving. I even will sometimes put color over the mitral and tricuspid valves to see if there's rip-roaring regurgitation going on, which may be a cause of your pathological state that you're in. And now I'm really looking at the pericardium and if there's an effusion. Now you can have, I know you know this if you're medical, you can have a pericardial effusion without having tamponade. What's tamponade? That's when you have so much pressure around the outside of the heart that it's compressing the chambers of your heart so they can no longer functionally pump. And it's a very dangerous state, and someone can die quickly of that. Here is the sign of tamponade. Diastolic collapse of your chambers. Diastolic collapse of your chambers, which usually starts in the chamber with the lowest pressure, which is the right atrium, right? Why do you have diastolic collapse during tamponade? Well, during diastole, that's when the chambers are relaxing and their pressures are low. And if you have tamponade, you get collapse during diastole, because the pressure outside the heart is now greater than inside the chambers, and you get collapse. If you have diastolic collapse, that's a clear sign of tamponade. You can also have something called respirophasic changes, which is a sign of pulsus paradoxus. Again, I think I'm getting too much in the weeds from non-medical people. I'm going to leave it at that. But you can definitely diagnose tamponade on point-of-care ultrasound without being a cardiologist. Now, if you have collapse of the other chambers, you definitely have tamponade. If you have systolic collapse, you have impending doom going on, and that patient needs emergent pericardicentesis. Okay, and then I'm still on the cardiac exam, and then I bring my probe to subxiphoid or substernal, what we call it, and you put that probe really flat on the belly, and you're looking up at the bottom of the heart. And the first thing you're going to see is the right ventricle and the right atrium, right ventricle kind of moving along. Again, you can look at the tricuspid annulus, see how rigorous it's moving. This gives you qualitative views of the right side of the heart. I forgot to mention the four-chamber view. You can also, you're looking at qualitatively how the heart is moving. And I also will do a quantitative measurement called the TAPSE, the tricuspid annular plane systolic excursion, which this all sounds very complicated and fancy if you're not familiar, but it's really simple stuff. I wish you were here with me and I could just explain this to you. It's so easy. The TAPSE is usually just looking how well the tricuspid annulus is moving. And if it's moving very rigorously, you have good RV function. And the same thing with a MAPSE, mitral annular plane systolic excursion. It's the same thing. Anyway, with the subxiphoid, I'm also, I'm looking at the heart, but now you're looking at the IVC. You're looking at what I look at. There's a lot of confusion with the IVC with an ultrasound exam. What I'm looking at, what I'm concerned about with, is the IVC super fluid overload? Is it plethoric? Does it look huge? Is it greater than 2.5 centimeters? That means there's probably fluid overload going on. Maybe not fluid overloaded, but RV failure going on. Now, the IVC is not a good indicator of someone's volume status. It's just not. We like to act like it is in medicine, their IVC was was fine. So it's not a good indicator of volume status. It's not, and neither is CVP, measuring the CVP. They're very equivalent things. So you cannot hang your hat on your IVC exam. You can't do it. All I care about is extremes. Is it super, super sucked down, or is it super, super overloaded? That gives me some clues. Another thing that will give you a clue on this, with this exam, looking at the IVC, is you can look at the hepatic vein. You can put a little color on it, and you can see if you're having flow reversal. The flow of your hepatic vein should be going toward the heart, not towards the liver. If your flow is going towards the liver, you probably also have RV failure. These are all quick things you can do that give you an insight of what's going on. There are many, many, many more things that you can do on a quick cardiac exam that can give you a lot of insight about what's going on. One thing is a caution of warning. Do not catastrophize what you're seeing. I can't tell you how many times I think I'm seeing something bad, and then I order a formal echo, and it's not there. Doubt yourself is what I'm saying. Doubt yourself on point-of-care ultrasound. Don't freak out unless there's obvious things like tamponade, or but like don't be like, oh my gosh, I saw this, and go tell everybody. Be like, I think I saw this. I'll get a formal echo. The patient's stable. We don't need to act on my findings. You got to be very careful. Do not hang your hat on your exam. All right, now let's move on to lung exam. By the way, with the cardiac exam, you need to use the phased array probe or the cardiac probe. With a lung exam, a lot of people will use the phased array probe. I use both. I use the phased array probe and the vascular probe, the flat probe. Anyway, what can you do on a ultrasound lung exam? Well, you can very reliably rule out a collapsed lung or pneumothorax. I like to use the vascular probe because the pleura is right next to is very close to the surface, just right beneath the ribs. And I want to zoom in on that, whereas the phased array probe is a little deeper. Anyway, I put the vascular probe on, and you're looking for lung sliding. Sometimes it's called ants on a logs. It's kind of this glistening appearance. You gotta look at videos. You can also do M mode through that, and then look for the barcode sign or the sandy beach sign. That stuff you can Google look up imaging. Very, very basic stuff. But I will tell you that the ultrasound exam is very, very sensitive to rule out a pneumothorax. It's even more sensitive than a chest X-ray. But you have to do it in multiple lung fields. You can't just look at one lung field. You got to do it in like at least 4 lung fields on both lungs to rule that out. And then this is at the point where I put on a phased array probe, and then there's the you look for the A lines and the B lines, which if you're familiar with, the B lines, or they're called like the rocket lines, that can be a sign of too much fluid in the lungs, pulmonary edema. And then I come down to the diaphragm, and you can rule that in effusion. You can look to see if there's fluid around the lung. There's something called the dolphin sign, which is a clear sign that the lung is now, that there's an effusion. And if you see an appreciable effusion and it's affecting their clinical exam, like they're having trouble breathing, whatever it is, that can give you a sign that you can put in like a chest tube or a pigtail to drain that effusion around the lung. So ultrasound is extremely useful with a lung exam as well, of course. Now, a big part of this that I'm sure people have been screaming is, okay, talk about the FAST exam, which stands for, I forgot what it stood for. It's funny, you do stuff for so long, you forget what stuff stands for. FAST stands for Focused Assessment with Sonography for Trauma. And basically, you're looking to see if someone is bleeding. For the FAST exam, you're doing there's 4 different regions. You're doing the rapid quadrant. You're looking at the pleural space. You're looking at the hepatorenal space, called Morrison's pouch. You're looking at the subphrenic space. You're looking to see if there's blood within these areas in the Morrison's pouch. And then you go to the subxiphoid, here, which I talked about earlier, and you're looking at the pericardium to see if there's bleeding around there, or like a tamponade. And then you're looking at the left upper quadrant. You're looking at the pleural, again, the pleural space, the splenorenal space, looking to see if there's blood around there. And then the suprapubic, which you're looking at the what's it called, the pouch of Douglas, to see if you're seeing blood there as well. So that can help you to know if someone has bleeding. You pair that with a physical exam, that percussive wave, whatever, and you can be like, I suspect this patient is bleeding. Maybe they need more advanced imaging. So again, all of this ultrasound, all this stuff is to then inform your decision making about, okay, I need advanced imaging. It helps guide the direction of where you can go. So those are the kind of the basic point of care ultrasound that you can do. And again, you do all these things, it takes you a few minutes. You rule out so many things. You can rule out, why is someone in shock? What's going on? Does someone have a collapsed lung? Are they bleeding? It gives you a big picture idea of what's going on with the patient in that moment to guide your clinical decision making. You pair that with a physical exam, And now you are a very well equipped clinician to really bring a patient out of danger and to stabilize them. It is a highly useful thing. Point of care ultrasound should be the standard of care. All clinicians should should know how to do it. So, I really got experience with it during residency. I made an active effort to do a bunch of cardiac exams, to do exams over and over and over again on as many patients as possible until I felt very comfortable. And I feel very comfortable with my point of care ultrasound skills that they do inform my decision making. I have caught many, many things that are endangering the patient and acted on those things based on point of care ultrasound. It is a crucial part of skill set for a critical care physician and an anesthesiologist and many other types of doctors and clinicians. So I highly recommend that you pursue education in point of care ultrasound and make it considered an extension of your physical exam. All right, I'll leave that for my kind of clinical portion of this podcast. Let's move on to my book analysis, which I do with every podcast. I usually talk about a clinical thing, and then I talk about books because you know how much I love books. So today we are going to talk about Hate Inc. Why Today's Media Makes Us Despise One Another by Matt Taibbi. His last name is Taibbi, and I always mispronounce that name. I'm sure I've mispronounced it here. Now, this author he's a controversial guy to the point where I don't even know if I should be promoting his book anymore. I'm not promoting it, but I do recommend this book. He's written 2 really well-written books with really good journalism. This book, Hate Inc., and another book called Griftopia. He's kind of gone off the rails a little bit if you follow him on Twitter, just talking about censorship, which censorship is an important issue, but anyway, I don't even know the full extent of his controversy, but just take it with a grain of salt. But he has written some good books, and this is one of them. Basically, the point of this book, to sum it down, is the news is a consumer product. And you need to remember that every time you read an article or watch anything. So told with a narrative voice that's pretty rough around the edges, the author gives a really jabbing insider analysis of the media engine that it's really thought-provoking for any partisan. It doesn't matter what your ideology is. And basically he makes, Chomsky's Manufacturing Consent, this classic book, really thematic for this whole book. He gives a tirade of the false dichotomy that's been set up in news media. By giving a false sense of dissent, that the viewer or reader is getting the inside scoop about the vile, quote, other, the media serves as an enormous distractor to the power structures that are at play in the background behind everything. Media moguls and corporate self-interest, corporate legislation. As long as someone is focused on their hatred of Trump, whether it's Trump or the libs, owning the libs, whatever, they won't ever have to actually ponder the bigger problem, which is this. America is actually an anti-capitalistic, anti-democratic, plutocratic, and imperial state, which those are my words. This is what I believe. But you'll never see these things in the headlines. And when I say anti-capitalistic, I mean anti-competitive. We do not have free markets. Anyway, one can speculate about media elite collusion with the plutocracy, the rich people that run everything, which no doubt is present. However, the aim is always self-interest. Hate sells. Hate and outrage sell. Hate gets eyeballs on the screens. Hate keeps you scrolling. Hate is addictive. As long as you hate your ideologically opposite neighbor more than the corporate elites, everything will hum along nicely for these news agencies. The constant focus on Trump's words, back when he was president and now, and his tweets back when he was allowed to tweet, without policy analysis, has made the media a ton of money over the last 4 years, 5 years, 6 years now. The truth is simple. The media absolutely loves someone like Donald Trump. They love that he was president because they have something for most Americans to hate every single time they look at the news and to stay on that news. The media is an implicit partner in the rise of Trump. For decades, the media has cultivated a cult of likability, or who would you rather have a beer with? Nonsensical litmus tests that have absolutely no bearing on the fitness for leadership, right? These beauty pageants gave way to the WrestleMania-like stage acting that welcomed Trump onto center stage. The arena was primed for a grandstander like Trump. And all those working-class Americans who the media elite has never actually cared about, they gleefully voted for this, racist, vitriolic man. The media started the class resentment that gave rise to a demagogue. I don't know if they started it fully, but they're implicit. there was a transition sometime in the 1990s from like the sleepy and unified news media that was trying to gobble up as much mass audience as possible to the siloed audiences where media could lean into their ideologies as much as possible. Clearly, social media and the destruction of newspaper advertising was a driver for this. Now media outlets try to heat up the ideologues as much as humanly possible by becoming more and more selective about what they report. Moral panic has become the last dependably profitable format of news making. The author spends a lot of time on Trump and Russiagate and how the extreme, how little data and evidence there actually was of Trump actually colluding with Russia, which brought about like unprecedented journalistic, focus that was close to the weapons of mass destruction thing with Iraq, which the news was also complicit with. So with regards to the Russian 2016 meddling, what we heard is that 126 million Americans were exposed to fake Russian Facebook accounts. What we didn't hear was the context of that. The exposure represented, and this is not an exaggeration, the author brings this up, 0.000000024% of the Facebook content over that 3-year period. It was a drop in the bucket, and the scale of the issue was very likely exaggerated. Why? To keep your eyeballs on the screens for advertisers. The bottom line is that most media actually does report facts, but it's highly selective, and it is the context and the caricatures that are fake. All media is guilty of this, both sides, and almost everywhere. The author actually makes the argument that you do not need the news, and you should just shut it all off. He says that there are so many bad things in the world that one person cannot possibly do anything about it, so they might as well live their lives and take care of their family. I wouldn't argue this at all. Rather, that if you're going to consume media, you should do it from as many sources as possible with as much scrutiny as possible. Overall, it's a good read. It's a unique insight. There's a bonus Chomsky interview at the end that's worth checking out as well. All right, let's move to answering some questions. Here's a question from TikTok. This is from @ohmymoose, which is a great username. This person says, "Hey doc, what qualities do you think make for a good nurse? I know you're mostly in the ER, but I'm ICU and I'm curious." I'm actually in the ICU. So a lot of people confuse the ER and ICU, but not that this person did it. This person was just misinformed for my account. Anyway, so what qualities do I think make a good nurse? So number one, I'm not totally qualified to answer this question because I'm a physician. So my perspective and our expectations were of nurses might be skewed. But from my perspective, what makes a good nurse is, and this sounds cheesy, but caring about their patient. I mean, it's obvious, advocating for their patient. And when a nurse advocates for their patient, it can sometimes come off to providers that they're annoyed or that nurse is constantly on them, blah, blah, blah. But that nurse is just being a good nurse, doing their due diligence, asking questions. I mean, the most fantastic nurses that I work with are always like, what about this? What about this? And I've talked about this a lot, previous podcasts and on TikTok that the nurses have an incredibly diverse job. They're balancing, the bedside nurse is just balancing so many things, being a liaison with the family and the patient and all the consulting services that come, and the physician or the PA and the NP, and just they're coordinating all that stuff. They're expert communicators, and they just balance so many things. And so nurses just being curious is being curious about why things are happening. And if you don't think you understand, it's not because it's probably because you don't get it. It's probably because someone is not thinking deeply enough, and that you should bring it up. Why aren't we doing this? Why aren't we doing that? I can't tell me how many times I've changed my thought process or care about a patient because of a nurse suggested it. It happens every single day, every day. I mean, I have such fantastic nursing, relationships with nurses where I work. It's just, they're my colleagues. If a nurse comes up to me hey, let's do this, that, I'm like, great, that sounds perfect. Because medicine is this art form. There's not always hard and fast rules. There are a lot of them. There are many things we know that we should do that are hard and fast. But there's just and I like being flexible with working with people how they want to do things. And if not just nurses but respiratory therapists or whoever, if they want to do things this way, then let's go ahead and let's do that way. Let's see where we get. Obviously, I'm not talking about extreme different practices of medicine, but there's many roads that lead to recovery, right? So I honestly think just being authentic to yourself, being authentic to your patient, don't be afraid to speak up. You will be respected by you if you speak up. And if you're not respected, that's not your problem. That's the receiving end's problem. They have an issue that you're not that you're not going to solve. So that's to me that's what a great nurse does. All right, I'm going to wrap up this episode. Thank you for joining. Please give me ideas about things to talk about this podcast. Now, I really wish I had guests on the podcast, but it's very hard because I don't really sit down and just record this in one session. It's in like snippets here and there, like before and after work. I have a busy schedule with my work schedule, and I'm a dad, and I'm a husband, and I have a home, and I have a beautiful little cat. So it's really hard for me to sit down in a solid chunk of time and have a guest and do that. I do want to do that. It would make this podcast much better. This echo chamber is going to get old real quick. I get sick of talking. So I do hope to do that. But anyway, in the meantime, please give me ideas of what you would like me to talk about. We can talk about anything. My email is icudoctorecmo@gmail.com, icudoctorecmo, ECMO @gmail.com. My TikTok handle is icudoctor. And then Instagram, it's icudoctor TikTok. So please email me with suggestions or feedback. Tell me things you don't like, things that you do. And if you have questions, I will prioritize them for my email rather than TikTok because I want to answer questions for people that actually listen to the podcast. And leave a review and share it with friends. Anyway, that's it. Thank you. Have a good week.